Welcome. Today we're going to be talking about the superior capsular reconstruction for the treatment of massive irreparable rotator cuff tears. We have with us in the studio Dr. Steve Burkhart from San Antonio, Texas, and Dr. Alan Hirahara from Sacramento, California. Thank you for joining us.
Thanks, Chris.
So Steve, what do you do in a patient who is 45 years old, let's say, and has a truly massive irreparable cuff tear?
Well, Chris, I've said for years now that most of these tears are repairable. In fact, in my experience, 95 to 97% of them are going to be repairable. But for those 3 to 5% that aren't, there are some other things you can do. And if you look through the literature, it ranges from arthroscopic debridement, arthroscopic tenotomy. You can do a partial repair. That's something we have done a lot in the past, and those that weren't truly repairable. Some people advocate tendon transfers, like a latissimus dorsi transfer, if there's a massive tear with loss of external rotation. And some people, believe it or not, are actually advocating reverse total shoulder replacement in some of these, even in younger people, which I think is against some of the principles of joint preservation that we like to think of.
Where they don't have arthritis.
Even when they don't have arthritis, absolutely, which I think is something I've never wanted to encourage.
Any other options, Alan?
Well, there's a new option, and that's the superior capsular reconstruction. This is a new concept, a new idea that Dr. Teruhisa Mihata published in 2013, a study that showed his clinical outcome of 24 patients. And it showed that the acromiohumeral distance went from an average of roughly 4.3 to 8.7, which is a significant improvement. It also showed a significant improvement in VAS and ASES scores as well.
Now, how long has he been doing it for?
I think he started doing his research in 2005, but he started actually clinically doing it on patients in 2007. He published a paper in 2012 showing that the superior capsule was an important structure in the joint. What this allowed was to keep that humeral head down and located. We all used to think it was just the rotator cuff, but it turns out the capsule is an important structure. And he found that if you take away the capsule, you get significant superior migration. With just the capsule alone in place, it can restore it to almost normal. So the concept here was where we cannot repair or replace the rotator cuff, we can at least replace the capsule to allow it to be stable so the rest of the muscles actually can function and make the joint work.
So Steve, what is the superior capsular reconstruction?
The people that I'm doing this operation on typically have proximal migration. They've formed an acromiohumeral fulcrum, and they don't have a stable fulcrum of motion for their force couples to work around. So what this graph does, if you want to think of it like a reverse trampoline that holds the humeral head down and fixes a fixed fulcrum so that the force couples can work around that fixed fulcrum, because that's how they're most efficient.
Now, anatomically, can you describe the procedure, Alan?
Capsule has to be reconstructed. The capsule runs superiorly, just medial from the labrum, all the way out to the tuberosity. So what we're doing is we're taking a graft and attaching it at that aspect of the superior glenoid, just medial to the labrum, and going all the way to the tuberosity to reconstruct that capsule.
So in this patient, back to this patient, Steve, 45 years old, truly massive irreparable cuff tear. In this case, superior capsular reconstruction?
Yes, absolutely. That's, in the past year or so, I've done 8 of these. I've been, although it's too early to tell exactly how they're going to turn out, I've been very impressed by the way they are doing extremely well at early milestones. So I think that when you look at what the alternatives are and what the early results seem to be, that's what I would recommend.
Do you feel like you've burned any bridges, Alan, let's say, in this, with this procedure?
Not at all, and that's the beauty of this. So even if we go ahead and attempt this type of a procedure, we can always turn to reverse later on. This absolutely does not close that off.
So gentlemen, let's talk about the technique of the superior capsular reconstruction. We'll typically make 2 portals, a lateral portal and an anterior superolateral portal, as our working portals. And then we'll take a good look around and determine if the rotator cuff is truly irreparable. Once we determine that it is, we may consider at that point in time doing interval slide. Steve, you want to comment on that?
Yeah, the interval slide is something I might do anyway if I'm not sure that it's repairable or not. Because if you have some tissue that's fairly robust and it's not totally scarred in medial to the glenoid, some of those are repairable. And so if you do the interval slide and you still can't get it to reach over to the beyond the articular margin, what happens by doing that posterior interval slide, it opens up that superior glenoid so that you can get to it much easier for placement of those anchors on the glenoid. So, where I would decide if I were going to actually use this procedure is if I had an active person preferably younger person that had a normal articular cartilage, that is, it's not a total joint replacement from that standpoint, and has an irreparable cuff tear. That is, the supraspinatus typically will be the one that will not come over to the tuberosity. Sometimes supra and infraspinatus, but generally it's going to be the supraspinatus. In that case, what I'll do then is I'll repair the infraspinatus as much as possible, advance it, and then if there's a subscap tear, which 75% of mine that I've done this procedure on have had subscap tears, so I'll repair that, and then I'll do my dermal allograft.
So what do you gentlemen do with the biceps? That always comes up. Do you leave it alone? Do you debride it? Do you do a tenotomy, a tenodesis?
Well, if the biceps is actually intact, I leave it alone. If there's definite pathology and if it's definitely something that needs to be addressed, I like to do a tenotomy. The problem is this person down the road might need a reverse or actually another prosthesis down the road, so I want to kind of not give a stress riser by putting another hole into the humerus further down. But tenodesis is definitely appropriate. But again, if it's intact, which a lot of these people, it turns out it is sometimes, leave it alone, leave the labrum alone, and just try to recreate the anatomy as best we can with a capsule.
Steve, what's your thoughts on the biceps tendon?
I'll usually end up doing something with the biceps if there's a problem with a subscap, which there has been in 75% of my patients that I've done this on. So if I'm going to do an upper subscap repair, I'm assuming that the biceps is unstable, so I'm going to do a biceps tenodesis at that point.
Another question that comes up all the time is what to do with the superior labrum. Do you put the dermal allograft, do you put it underneath the superior labrum? Do you remove the superior labrum? Do you put it medial to the superior labrum? Alan, what's your take on that?
My take has always been recreate the anatomy. The superior labrum has been shown in numerous studies that it's important for stability of the joint. And our whole concept here is that the superior capsular reconstruction is trying to reestablish stability of the joint. So I think by leaving an intact labrum alone, which will only help us with the stability, it's only going to be something that will help keep that ball in place. So we put the capsule where it belongs, medial to the labrum.
Steve, what are your thoughts on that?
In most of these, I've been able to retain the superior labrum, and it'll have some attachment still left into the bone. If in the course of debriding the soft tissue on the superior glenoid, the labrum becomes detached, so there's a big floppy piece, then I'll resect it at that point.
In terms of putting the anchors, typically we use a 17 gauge spinal needle and percutaneously insert the anchors. It seems like in the majority of cases that anteriorly we're able to go anterior to the acromion. Posteriorly though, we either have to go through Nevisor's portal or posterior to the acromion or the spine of the scapula. What are your thoughts, gentlemen?
I agree. It just totally depends on where you're wanting to put your anchors. If you do put one through the Nevisor, you've got to be careful because your overriding principle here has to be that you're not going to penetrate through the articular surface of the glenoid. So you have to be really cognizant of that angle of approach. And so if you're going through a Nevisor portal, you have to be as far lateral as possible through your Nevisor portal, almost right up against the bone.
Alan, what is the importance of measuring the distance between the anchors?
The distance between the anchors allows us to do several things. First of all, it allows us to be able to determine the exact placement and punch the specific holes into the actual graft so that it will lay down perfectly. There will be no dog ears, it won't be stretched too much, it will be nicely tensioned just the way it's supposed to be. In addition to that, it will also allow us to see what size graft we need, because then we can also measure the distance between our anchor placement and the residual tissue to know exactly the size of graft so we can cover the exact distance and cover the exact defect exactly.
Now, do you add anything to your measurements, anterior, posterior, medial to lateral? Do you add anything to them?
On average, I like to keep those anchors within about 5 to 8 millimeters to my residual tissue in all directions. That way then I only have to add about 1 centimeter in all directions. So 2 centimeters added to my anterior posterior distance and 2 centimeters added to my medial lateral distance.
So Chris, have you got some pearls you could tell us about the distances between the anchors, something that you've noticed that would help us out?
Yes, we've noticed in the lab, Steve, that if you look at the distance from medial to lateral, comparing the anterior anchors to the posterior anchors, that the posterior anchors are separated by 5 millimeters more than the anterior anchors. So let's say you've placed all 4 anchors in the technique that all of us do, and you're measuring the distances between the anchors and the soft tissue. What is the position of the arm? What position do you have it in, Alan?
I like to position it natural, neutral. So it doesn't mean zero adduction or abduction, it means just at the side, which all means it has a little bit of abduction to it, but then neutral rotation. I'm trying to put the graft where it's going to live normally every day so there's no tension on it.
Steve, what are your thoughts about the arm position?
I have it in my standard lateral shoulder arthroscopy position, which is about 20 degrees of abduction and 20 degrees of forward flexion and neutral rotation.
Alan, do you use the double pulley technique or do you have a different version?
I very much like the double pulley technique. So the double pulley where you take the sutures up through the graft and then take one limb from each of the sutures and tie them together. You're able to then pull on those other two limbs, and what it does is it pushes the graft down onto the bone. And I'm able to use a double pulley both on the medial and the lateral side. This allows us to set the graft into position without it twisting, turning, or getting bunched up. And it makes things easier in placing the graft.
Steve, when you're passing your sutures through the graft for the glenoid component of it, do you pass it through 2 passes or 4 separate passes? Do you think it makes a difference?
I like it better if I can go through 4 separate holes because you end up then with four fixation points in the dermis, which makes it more stable down against the bone. And you end up with kind of a more distributed load across your double pulley configuration over the top of your graft. And then after I tie those, then I like to leave the limbs long and then bring those long limbs up through whatever tissue that's still there medially and whatever remnant there might be of supraspinatus so that I can bring that soft tissue to that medial side of the graft for hopefully some vascular response and vascular ingrowth there.
Alan, how often do you do the standard double pulley technique as opposed to the pasta bridge?
So the double pulley where we use actually a static surgeon's knot is a great alternative. We've shown in some of the biomechanical testing though that applying a third 3.5 swivel lock medially on the glenoid neck, a la the pasta bridge, has shown much stronger fixation ability. So we've gone from 550 newtons, and of course a static surgeon's knot is excellent still at 480.
Now, what are your thoughts about single versus double row for the fixation on the greater tuberosity, Steve?
Well, I prefer the double row. I think it stabilizes the graft better, helps to eliminate any dog ears better, and it gives you firm compression. I think that's where most of your healing is going to take place, is vascular ingrowth from the bone, so I want to have as much good contact there as possible.
And I think there's also an added advantage of a biologic tuberoplasty. Just in case the graft ever did fail, you do have a biologic tuberoplasty in place. After you've completed the superior capsular reconstruction, if there is rotator cuff that you can fix, I mean, what do you do in that situation?
This has been actually something that's been very useful. You can actually incorporate cuff repairs into the SCR. For example, I've taken the infraspinatus posteriorly, and before fixing the speed bridge posteriorly, I've passed my fiber tape as well as my fiber wires up through the residual cuff tissue and incorporated it into the actual speed bridge repair.
What about for a U-shaped tear? Let's say, Steve, you had a U-shaped tear. Would you do the superior capsular reconstruction and then repair with some side-to-side sutures, if you could, some of that U-shaped tear afterwards?
I think that makes perfect sense. You may have one that you can achieve a significant amount of margin convergence to cover over the top of your graft. And I think there again, that's a potential source of vascular supply for your graft.
And it's anatomic with the capsule beneath the normal rotator cuff. Steve, do you use side-to-side sutures?
Yes, I use side-to-side sutures between the graft and the infraspinatus. And I think that's very important in terms of linking your graft to your dynamic muscle tendon unit and just making a continuous sheet, and also so you won't get that posterior subluxation potentially like Mahata had shown, and also to provide some potential vascular supply from the infraspinatus. On the other hand, oftentimes there's not any soft tissue anteriorly to tie into. If there is some remnant of the comma tissue, I'll tie into that anteriorly. But you don't want to overstretch your graft and try to go all the way down to subscap, because that would not be physiologic there.
Now, Steve, you said something interesting about revascularization. Have either of you noticed anything with any of your imaging of revascularization?
Yes, we routinely ultrasound our patients after surgery. We've been noticing at about 6 to 8 months, we're seeing actually pulsatile vessels within the graft itself, just above the tuberosity.
So do you gentlemen do a subacromial decompression? Do you do an acromioplasty in this situation?
No, I don't do it because, typically you're looking at patients that have proximal migration, they've developed an acromiohumeral fulcrum, and you sure don't want those people to develop anterosuperior escape. So I'll do a subacromial smoothing. I may do a lateral bevel on the acromion, but that's out beyond the CA ligament, just so that it doesn't tend to impinge out laterally so much. But I certainly would not do a standard acromioplasty.
Alan, do you think it is a spacer, or do you think that there's mechanically something going on with the superior capsular reconstruction?
At this point, we can safely say that is not just a spacer. There may be some spacer effects from it, but we know that it's actually a superior capsular restraint. And we know this for several reasons. Number one, we're only using a 3.5 millimeter graft. And we've been seeing acromial-humeral distances that are augmenting over almost 4 to 5 millimeters. That's not just 3.5. In addition to that, we're seeing that even when the humeral head then starts to show abduction, it still stays down. We know that that graft is going to get a little bit looser from a medial lateral area, but Dr. Burkhart has shown us that that cable suspension bridge is important, and that's why it's so important to make sure it's attached appropriately anteriorly and posteriorly, especially in the interspace, as Dr. Burkhart has said, to make sure that it tensions it and keeps it down.
Yeah, I think one of the things that happens along those lines is that it does bring the humeral head down, recenter it on the glenoid, and if you have a stable, fixed fulcrum of motion for the shoulder, that's when you have the most efficient force couples. So I think you're maximizing the efficiency of your force couples by centering the humeral head on a fixed fulcrum.
And we've noticed that in the lab, when we carefully dissected the deltoid away and had the superior capsular reconstruction exposed, that we couldn't, even with maximum axial loading proximally, we couldn't get the graft in the humeral head to hit or abut the undersurface of the acromion. So I agree with you. I don't think it is a spacer. Alan, what is the difference between Mahata's graft and the graft that you're referring to?
Dr. Mahata first described using a fascia lata autograft from the individual patient's hip, having to make these large incisions because he doesn't have access to allograft. And so it was an innovative, excellent technique that he's using. We're lucky here that we have the option for dermal allograft. This Arthrex dermal allograft is extremely strong. It's extremely robust. So we're able to use only a 3.5 millimeter graft, where he is using a 6 to 9 millimeter graft. So there's a difference because the strength of our graft, which we've shown in biomechanical testing, is, as I said, 550 Newton strength, as opposed to the fascial autograft, which has only shown 180 Newtons of strength.
So Steve, what is your rehab protocol with these patients?
Well, I do these just like a massive cuff tear, maybe even a little bit slower from the standpoint of active motion, but since I don't really know what's going to be happening with these and how fast they're revascularized, I'll keep them in a sling for 6 weeks, and then I'll do passive motion after that until 3 months. At 3 months, I'll allow active motion, trying to get overhead motion, because by then they've got enough, I think, scapulothoracic control that they can do that without having a lot of dyskinetic movements. And then at 4 months, I do strengthening.
Alan, what about yourself?
With me, we're a little bit quicker on this, and the reason why is that we tried holding people back, and people were having such amazing pain relief that they wanted to go faster. And then with the biomechanical testing showing such large strength of 550 Newtons pull-out strength, we went ahead and started doing actually passive range of motion starting at actually 5 to 7 days, and allowing progression based on just how they feel.
Gentlemen, any final thoughts?
Yeah, you know, I think that one of the things that's concerned me the past few years is that I've always thought personally that our primary concept in shoulder surgery should be joint preservation whenever they had a good joint to start with, that is, the articular surfaces are normal. The concern I've had in the past few years is that I've seen some of the people straying away from that concept and using reverse total shoulder replacement for massive cuff tears, even in the case of a person that has intact articular cartilage. So that's totally against the concept of joint preservation. And here we have a case where, sure, the rotator cuff may not be entirely repairable, but the joint is just fine. So let's preserve the joint and let's find a way that we can treat this with minimally invasive surgery in a way that minimizes complications, because the complications are much lower with arthroscopy. Not only the rate of complications, but the magnitude of the complications. There's no comparison between an infected arthroplasty versus an infected arthroscopy. So I think that we're doing a service for the patient, and we're hopefully preserving their joint, maybe not for the rest of their lives, but for a considerable time period.
Alan?
I'm just excited. This is just another option that we finally have between someone having a massive cuff tear with significant pain and dysfunction and a replacement. It gives us that opportunity potentially to preserve that joint for a longer time, but more importantly, it allows this person potentially to have less pain and more function when otherwise they had no real options. So now we have something to try that burns no bridges. We have something that even if we try and it doesn't work, it's no problem. You can still go on and have the reverse prosthesis. It's just one more possibility for us to try.
And we've seen tremendous interest, and we are encouraging all the surgeons to enroll their patients into the SOS Orthopedic Global Registry so we can follow all these patients. Gentlemen, thank you once again. I think this was very productive.
Thank you.
You're welcome. Enjoyed it.
All the pictures, animations, and videos in this presentation will be available on the Arthrex.com website. Please contact your local Arthrex representative to learn more about the SCR. We appreciate the opportunity to help you treat your patients better.